Hello everybody, my name is Simran Parmar. I'm an internal medical trainee at St George's Hospital in London, UK, and I'm pleased to talk to you today about anemia and iron deficiency in CKD and heart failure. So some of the aims of the talk. So one, I'd like to go through some of the indications and risks to iron and erythropoietin stimulating agents in CKD and heart failure patients. Two, to understand why some of these recommendations have been made by looking at some of the clinical trial evidence behind the recommendations. And three, we'll finish with a case study of a patient with CKD and heart failure and anemia. So a bit of background, anemia and iron deficiency are very common. They are both very strongly associated with each heart failure and CKD, and it actually forms a common triad of having anemia, heart failure, and chronic kidney disease. You can see here iron deficiency is very common in both acute and chronic heart failure patients, and anemia and iron deficiency are associated with morbidity in the form of hospitalizations and mortality. So interestingly, you can see at the bottom that in patients with CKD, they're actually lower than usual hemoglobin targets. In here, NICE recommending 100 to 120 and KDIGO 90 to 115. And the reasons why this is the case will be touched upon a little bit later on in the talk. So a quick note about blood transfusions. Blood transfusion should be minimized where possible in CKD patients, and the reason for this is that every blood transfusion may increase the number of antibodies in patients with CKD, which can make future workups for renal transplantations more difficult and potentially make them less successful. So firstly, looking at iron deficiency in heart failure patients. So you can see some of the causes up here, but it's multifactorial, including reduced oral intake and ineffective absorption. These patients will have the usual iron deficiency and anemia symptoms such as fatigue and decreased exercise tolerance. And you can see some of the indications for iron according to the ESC, European Society of Cardiology 2021 guidelines. So you can see here that there are three criteria. So having a hemoglobin of less than 150, as well as having heart failure with reduced ejection fraction, so that'd be ejection fraction less than 40%, and a ferritin of less than 100 or a ferritin of less than 300 with a transferrin saturation of less than 20%. So this is something that generalists can keep in mind when they see patients with heart failure, as it's quite this will encompass a lot of patients, as if they have HFrEF and if they have a hemoglobin less than 150, which most of them will, make sure you order a ferritin, because if the ferritin is less than 100 or less than 300 with a TSAT less than 20, they would meet the criteria for iron replacement. And this is an interesting note, as even if they had a normal hemoglobin of 130, they would still meet that criteria. Now, in terms of which type of iron to use, IV iron is the preferred type of iron for these patients, and studies have shown that oral iron is not efficacious and does have many side effects. So next, looking at iron deficiency in non-dialysis CKD patients. Again, very similar mechanisms, including decreased intake and decreased absorption. We would aim for hemoglobins of 100 to 120, and the criteria for these non-dialysis CKD patients are if the ferritin is less than 100 or if the transferrin saturation is less than 20%. Similarly to patients with heart failure, IV iron is preferred, as oral iron is not as efficacious and does carry side effects. And an example of a type of IV iron would be Ferinject, which is ferric carboxymaltose. Now, iron deficiency in hemodialysis patients. So again, the same target of 100 to 120, and you'll notice this time that the ferritin cutoff is a little bit higher, so we want to be more generous in giving iron to dialysis patients. So it's a ferritin of less than 200 or a TSAT of less than 20%. and iron in hemodialysis patients is often given into the circuit during hemodialysis sessions. Now, a very recent and a good trial recently was a pivotal trial, and this actually showed that, so this study compared two groups. They had a proactive iron group and a reactive iron group. The proactive IV iron group consisted of hemodialysis patients receiving 200 milligrams of iron IV in each of the first 2 sessions per month, and the reactive iron group just had IV iron with this criteria, so ferritin less than 200, TSAT less than 20%. And what the pivotal trial showed is that proactive IV iron was superior to reactive IV iron and had an improvement in the composite endpoint of MI, stroke, heart failure, hospitalizations, and death. So this is a very good study which showed that proactive IV iron, regardless in hemodialysis patients, for example, 200 milligrams in each of the first 2 sessions of hemodialysis, is shown to be beneficial in this cohort. So now moving on to ESAs, or erythropoietin stimulating agents. So these work because in CKD, patients often have impaired production and stimulation of EPO. These agents do what they say, they increase endogenous EPO. Importantly, patients must be iron replete for ESAs to work. If someone is not iron replete, you will give them an ESA, they will have the risks and potential side effects, but it will not be effective. Some contraindications here include previous stroke and active malignancy, and the reasons for these contraindications include the risks associated with ESAs, including hypertension and thromboembolic disease. So if someone has, for example, an active malignancy, they're already in a pro-thrombotic state, and giving ESAs in these patients will further increase their coagulability and can cause thromboembolic disease. Now, very interestingly, this bottom part is that we do not use ESAs to target hemoglobins of greater than 130. This has been shown to be harmful in both CKD and in heart failure patients. In CKD patients, you can see here that targeting hemoglobins of greater than 130 as opposed to 110 cause an increased incidence of cardiovascular disease and death. And similarly, in heart failure patients, targeting hemoglobins greater than 130 in HEF-REF patients cause an increased risk of thromboembolic events. So this is why generally in CKD heart failure patients we're happy to aim for a minimum hemoglobin of 100 to 120. Some general cautions and considerations. When seeing any patient with iron deficiency or anemia, you of course must always consider other causes, including more sinister ones such as malignancy. Ferritin is an acute phase reactant, so it will go up in states of inflammation and infection, and we generally don't want to give iron to patients during when they have infections, as it can increase the risk of infections. And finally, oral iron is not as efficacious as IV in CKD and heart failure patients. So on to our case discussion. So you can see at the top we are considering a 60-year-old male presenting with shortness of breath and a productive cough. He is admitted to hospital and he has a past medical history of heart failure with reduced ejection fraction, CKD4, and COPD. He's admitted with an infective exacerbation of his COPD and a decompensation of his heart failure requiring oxygen but no NIV. So we consider him on day 3, and he is on oral coamoxiclav or Augmentin, and he has successfully diuresed and he no longer has an oxygen requirement. He's looking well. You can see his observations are here, and some of his blood results are here, including a hemoglobin of 91 and a ferritin of 87, transferrin saturation of 26%. So now, going on to our first question, what would you do next regarding his iron status and anemia? So now please pause the video and have a think about what you would do. So The answer to this question is, of course, as with any anemia, we'd first want to consider other causes and exclude those, especially more sinister ones. Considering his eligibility for IV iron, he meets it with, from the heart failure perspective, you can see the hemoglobin and ferritin there, and he also meets it with respect to his chronic kidney disease, his ferritin of less than 100. However, he is still on oral antibiotics and he still is being treated actively for an infection, so therefore we would not want to give IV iron in this patient and we want to wait until his infection has resolved. Now, considering this same patient, we've seen him now 2 weeks later in an outpatient clinic. He reports feeling back to his baseline in terms of his shortness of breath and productive cough. However, he reports many months of fatigue. We repeat his bloods and we can again see an anemia of hemoglobin of 89, and you can see ferritin of 51, transferrin saturation of 25%, and clinically and as well as biochemically, it looks like his infection has resolved as his CRP is coming down to 11. So question 2, now what would you like to do regarding his iron status and anemia? So again, if you like, please pause the video and have a think. So based on his most recent blood tests, he would still meet the criteria for IV iron with respect to his heart failure and his chronic kidney disease. So therefore it would be entirely reasonable and it'd be good practice to give this man Ferinject. And after his Ferinject infusion, he notes that 3 months later he has an improvement in both his exercise tolerance and his tiredness. So now, considering the same man, 5 years later, he has now progressed from CKD4 to end-stage renal disease, and he is dialyzing 3 times a week. Someone has prescribed him oral ferrous sulfate, 200 milligrams once a day, and these are his bloods. So you can see hemoglobin of 85, MCV of 79, ferritin of 120, and transferrin saturation of 30%. So our next question, again, what would you do regarding his iron status and anemia? So again, please pause the video and have a think. So he has now progressed to hemodialysis, so some of the targets will change, but however, a good first step would be to stopping the oral ferrous sulfate. As we mentioned before, it often carries lots of side effects, particularly gastrointestinal side effects, and has been shown to be not as efficacious as IV iron. From the perspective of his heart failure, he would not meet the criteria for IV iron, as his ferritin is 120, but his transferrin saturation is 30%. However, he would meet the criteria for IV iron from the perspective of his chronic kidney disease, as we would aim for a ferritin of greater than 200 and a transferrin saturation of 20%. Now again, going back to the pivotal trial, which showed that a proactive iron regimen was superior to reactive, it would be reasonable to start this gentleman on IV iron infusions such as Venofer during his hemodialysis sessions, for example 200 milligrams of IV iron in each of the first 2 sessions per month. Now again, considering the same gentleman, he reports that 3 months later he has had a significant improvement in his exercise tolerance and tiredness, and we've repeated his bloods. Now we can see that his hemoglobin has improved substantially from 89 to 112. His ferritin is 300, transferrin saturation 35%. And so as per the pivotal trial, he is still receiving these IV iron infusions. However, the next question is, should we treat him with an ESA? And if your answer was no, you would be correct, as we mentioned previously, using ESAs to actively target higher hemoglobin levels above 120 and 130 has been shown to cause harm. As mentioned previously, a level of 100 to 120 is acceptable in patients with CKD and heart failure. Should this gentleman should his hemoglobin have remained less than 100 after being iron replete, then it would be absolutely reasonable to consider him for an ESA. However, you must consider the contraindications and cautions, including previous strokes, hypertension, and an active malignancy. So finally, going on to newer agents. There are newer agents called hypoxia-inducible factor inhibitors, such as roxadustat, and now these work in similar ways. However, they prevent the breakdown of hypoxia-inducible factor, thus promoting endogenous EPO production. The benefits of them over ESAs is that they are an oral alternative, and some patients may prefer taking an oral tablet as opposed to having injections Now these HIF inhibitors are mainly targeted at non-dialysis CKD patients, as many hemodialysis patients will be receiving iron and ESAs through their circuit when they go for hemodialysis. So the main group of patients you can consider these in are for non-dialysis CKD patients. And that's exactly what NICE have said. They can be considered in patients with CKD stage 3 to 5 not on dialysis. And trials have shown hypoxia-inducible factors such as roxadustat to be non-inferior when compared with ESAs such as darbepoetin alpha. So thank you very much for listening. These are some of the references, and we hope you've learned a bit about anemia and iron deficiency in CKD and heart failure, and we will see you in the next video.